Thank you. We'll have to move on to the next topic. I think first talk will be by Dr. KAALAN, right? Yeah. Okay, thank you.
So it is, in Chennai, it's almost 5 a.m. Is that true?
5 p.m. Saturday
Or
evening.
5 p.m. Almost 5
Yes.
p.m. Okay, so how are we on time? Should I shoot for 20 minutes or
We are
what's
good.
the goal?
You're good. You can go
Sorry.
on for 20, 25-ish minutes. This is the
Okay.
last talk, so we're not going to
Okay.
pressure you.
Okay.
Last session. Last session, there's one speaker after you. So anyway, we're not going to pressure you for time.
Okay. Can you see the presentation view?
We can.
Okay.
In a
And it's
moment.
KAALAN.
There's a huge discussion about how you pronounce your name.
Yes, it's KAALAN.
Does it have a meaning?
So my grandmother's maiden name was Kayland with a D on the end, her last name. So I'm 7/8 Norwegian and 1/8 Swedish. So it's probably a place in Norway that I will have to discover someday.
Great.
I was hoping to be able to see all of your faces, but
Uh,
let's
he
see
wants to
how I
see the
can do that.
audience. Can we show the
Well, I
audience
don't,
from there?
it's probably on my side, not your side.
Can you repeat that? Right. Are you seeing us?
No, it's not,
Cameraman?
it's something with
Audience?
my Zoom. Oh, I got it. I got it. There we go. I'm seeing the screen anyway now where you guys are. Way from intubation injury and prevention to the acute and the chronic and the postoperative management of our airway patients. The time they spend in the ICU is some of the most important time that they can spend. And so this is such a critical topic, and I'm excited to dive into it. I'll talk about not only the postoperative management, but also some additional protocols for that can be adopted in the ICU to just better manage all of the patients that we see with airway concerns. So I have nothing to disclose except that it is for 23 in Seattle, and I'll do my best to stay awake and engaged. But if I fall asleep while I'm talking, then I apologize. So we're taking care of all kinds of patients. And this is a 5-year-old who had Vactrol and complete tracheal rings and required a slide tracheoplasty. So when these things go well, they go well. And that's fantastic. A preoperative bronchoscopy for the complete tracheal rings on the left and a postoperative bronchoscopy 3 months later. Everything healed beautifully. She did great. She was extubated the next day in the ICU and had a very uneventful postoperative course. So when things go well, they go well. And that's amazing. And it's nice to have good ICU partners when things go well to work through those patients. But when things don't go well, they don't go well. And this was another patient who underwent a slide tracheoplasty, and the immediate post-operative endoscopy, things look fantastic. It was a near complete complete tracheal rings for the majority of the trachea. And so this was just intubating at the end of the procedure, and things are closed up nicely with good patency. We fit a nice sized endotracheal tube through, and the distal airway looked great. But we ran into complications in the ICU where The patient developed a mucus plug and had to be taken urgently to the operating room. We took that mucus plug out. A day and a half later, they developed a second mucus plug. We had to take them urgently to the operating room and take that second mucus plug out. And by the time we got to extubating this patient, I think with all the trauma to the mucosa and probably other factors as well, they developed a fistula at the anastomotic site distally. Thankfully, not a complete dehiscence, but this is a small fistula that developed, and the patient required ECMO for 2 weeks postoperatively. And thankfully, it survived and is doing well. But having the partnership with the ICU through those challenging experiences is even more critical than when things go well. So that's a surgeon's perspective as an introduction. I will talk through some postoperative protocols, especially single-stage laryngotracheal reconstructions is a critical piece of our armamentarium, and that requires a very intense partnership with the ICU team. I'll talk through some non-standard airway care protocols, including fresh trach, difficult airway, critical airway, both the protocols that can be used for like signs at the head of the bed, but also having a bronchoscopy cart and a response team available for those emergent airway calls that we receive. And then I'll talk a little bit about complication management with like vocal cord ultrasound protocols for vocal fold immobility, humidification protocols, and just the basic teamwork that we need to be striving for with our ICU. So all of you are familiar with the Cotton-Meyer subglottic stenosis grading scale. Lower grade stenoses can be managed endoscopically, and that's been discussed at length during this weekend. And higher grade stenoses should require procedures. And if it's a patient who has, who has good lungs and a relatively limited injury, you can consider a single stage laryngotracheal reconstruction. But if those things are not true, then a double stage is often the way that you will go. This is a rudder stent that we most commonly use, but other options can be employed. They're usually left in for a couple weeks. And when you consider a single stage laryngotracheal reconstruction, as I mentioned, you want healthy lungs, you want patients who will tolerate sedation well, and you don't want any risk of extensive postoperative edema. So if a patient has a hot larynx, if it took you, years to get that larynx to cool down for the reconstruction, then they may not be the best candidate for single stage reconstructions. But there's lots of patients who are good candidates to undergo this deep, tight partnership with ICU and the surgeons. And I wanted to introduce you to a few of those patients so we know who we are managing postoperatively. So that could be patients with an anterior tracheal stenosis or collapse, like suprastomal collapse could be a good candidate for a single stage laryngotracheal reconstruction with anterior costal cartilage grafts. That could be an anterior subglottic stenosis, again for the anterior graft. It could be an anterior and posterior stenosis. You can do anterior and posterior costal cartilage grafts in a single stage manner for some patients. And then posterior glottic stenosis or bilateral vocal fold immobility, and even patients who require a high tracheoesophageal fistula repair are commonly treated open, but can be considered for a single stage procedure with an endoscopic posterior costal cartilage graft or an open posterior costal cartilage graft, but those can all be single stage procedures. And then most of our resection procedures, including slide tracheoplasty, cricrotracheal resection, or tracheal resection, can be done in a single stage manner as well. And those are covered in other talks for the most part. But I'll introduce you to a couple of those patients. So this is a fascinating story of an intubation injury, actually, kind of dovetailing with the last talk that we had. This patient was intubated for surfactant delivery in the neonatal ICU, and a stylet endotracheal tube was used, and it went into the ventricle and actually dislocated the anterior commissure from the true vocal fold. So they were tracheostomized by my partner over the weekend, and I met them on a Monday and stuck a suture through that true vocal fold on the right passed it into the subglottis and tied it down. And thankfully, it was able to reapproximate the vocal fold, but the edema persisted and they kept their tracheostomy for over a year. That finally settled down at the glottis, but they developed this suprastomal collapse that was significant and precluded them actually being able to cap and decannulate. So they were a great patient. Their glottis worked. Their cords actually opened and closed, had a decent voice, but a great patient with that type of collapse for a single stage anterior costal cartilage graft. That's immediate post-op and post-extubation. That patient did very, very well. And this is another patient who had undergone an anterior posterior costal cartilage graft reconstruction, but still took a 3.5 endotracheal tube pre-op. So we just did a single stage for an anterior graft for that isolated anterior stenosis and opened things up to a 4.5 and did well with that. This is a patient who had an anterior and posterior kind of a circumferential congenital subglottic stenosis, but a very clean, healthy airway. They had undergone their preoperative workup and there was no signs of inflammation. So we felt they were a good candidate for an anterior and posterior costal cartilage graft and doing it in a single staged manner. They'd never had a tracheostomy and the family wanted to keep it that way. One more patient with posterior glottic stenosis and bilateral vocal fold immobility. So we actually took them for a single stage endoscopic posterior costal cartilage graft. And this is the immediate post-op and the late post-op appearance for that. Again, these patients who've never had a tracheostomy, it's sometimes difficult to convince the family to undergo a double stage procedure. And if you're careful with your post-operative management, you can get away with that, but you do have to pick those patients carefully. And the last patient I'll introduce you to with a single stage approach is a patient who actually had a recurrent H-type tracheoesophageal fistula. They had undergone a distal C-type tracheoesophageal fistula and esophageal atresia repair as a neonate, but had an undiagnosed laryngeal cleft. And when they developed pneumonias, were sent to us. And my partner, Andy Inglis, actually did a type 3 laryngeal cleft repair. It went all the way through the cricoid, a type 3A. And the top of the repair healed relatively well with some endoscopic attempts. I met her, she still had a type 1 and the fistula and closed the top, and that sealed. But I attempted to close this fistula in the inferior aspect of the cricoid twice, and the second time it just got bigger. And so that tissue needed some additional support. So the traditional approach that I was taught for that was an open laryngofissure and a posterior costal cartilage graft. But this is a 16-year-old girl who had never had a tracheostomy. And so we wanted to consider taking her for an endoscopic posterior costal cartilage graft. But when you have a deficient cricoid, you have to kind of take a slightly different approach for that. With a type 3 post-laryngeal cleft, there is no cricoid in the posterior glottis. And so you have to consider being a little bit more proactive with securing a graft if you're going to do that. So this was the approach that we decided to take for that. So this is assessing for that fistula. You can see the top of that repair had healed, but inferior to that, there's actually a relatively large fistula still that has persisted despite the initial repair and 2 additional endoscopic attempts by me. That remained. So we decided to attempt a layered closure. So freshened up the edges, both with cold steel and Bugby, and then through some sutures through the larynx to close the posterior mucosa. And you can see 3 sutures with 6-0 PDS on a BV1 needle back there to close the mucosal layer. And then we placed a suture through the cartilage of the lateral cricoid. So again, it's deficient for the cricoid in the midline, but there was cricoid that we could palpate laterally. So this is taking that 6-0 PDS on a BV1 needle, bending it a little further for a tighter radius of turn, and then being able to pass that through the cricoid on the left side. That was again repeated on the right side. We dissected out a pocket inferiorly so that the tip of this graft could be received by a mucosal pocket within the trachealis. And then we were able to pull down the sutures on each side and advance the costal cartilage graft into the trachea with the tension provided by the sutures and also pushing directly in with the alligator. We're able to notch that into the mucosal pocket that we had created. So you'll see as the tip of this graft gets pulled in, it's actually pulled underneath the mucosa and is notched into that inferior mucosa, and we push that down into place. And then this is the immediate postoperative bronchoscopy, where you can see the graft is held in place by these two sutures laterally to prevent it from falling out, because the cricoid, again, is deficient on the sides. It was a little bit proud at the back. I wish it was a little flatter at the posterior glottis, but it stayed very securely in place while this healed. And most importantly, the fistula was able to close with that. So the diagram for that graft I'll show next looked like this, where the tip of it was inserted into that mucosal pocket, and then the sutures out to the sides were held in place. And this is the immediate postoperative appearance. So again, that proud part of the graft. 6 months later, that settled out a little bit, and that child did well. But you can imagine when you do all this work into a surgery, you really want these repairs to hold, and you want the grafts to sit, and you want everything to go perfectly. So how they arrive in the ICU and how they're managed is critical for the success of these delicate surgical repairs. So what I'll often try to do especially in the older patients, is an awake nasal intubation. And this is what you can often achieve. We see our teenagers playing video games with an endotracheal tube in their nose. And if you can do that and avoid the deep sedation for that week, it's really nice to limit the withdrawals that they have to go through. We will be planning to do an airway endoscopy at 1, 2, and 4 weeks. And at the 1 week endoscopy, we'll downsize to a one size smaller endotracheal tube and usually extubate the next day. But we've been able to have patients wake up with a nasal endotracheal tube down to, I think my youngest is probably 4 or 5 years old, but I know other places have gone even younger than that. And then if they do require sedation, you have to be careful and protocolized with the management of that to limit the amount of sedation that is given, to keep them safe and not have them moving around or rubbing the tube, but to keep them as alert as possible to limit withdrawals on extubation. So postoperative order sets for single stage reconstruction with all the things that you might need, all the medications, the antibiotics, the acid suppression, all those things are important to have thought through ahead of time with the ICU. And for staged reconstructions, the same thing. So having that all in place is critical. So that's post-op stuff. I'm also going to mention fresh trach protocols and difficult critical airway. This is actually a true story from an interaction with an ICU. Trauma, Michigan, that's identifying the patient. PICU, stat, bring your NP scope. And so I'm like, which ICU is it? Which room is it? How old is the patient? What's the airway problem? Like, NP scope isn't going to help me if I need to do a slash trach on this child. So communication with the ICU is so critical that developing protocols around how to do that more effectively than this is something that can be really important. So this was a patient that prompted one of those protocol evaluations when I was in Cincinnati. They came into the trauma bay with an airway foreign body. There was a delay in transporting the patient to the OR, and they nearly died in the ER. So it prompted this protocol to be developed, and the publication that came from it subsequently. We actually utilized in situ surgical simulations where mannequins were rolled into the trauma bay, and we watched how the team reacted. 6 of those using the existing the system, and then we introduced a novel system of care with airway cards and a protocol and airway cart. And then we watched and saw what happened. And with the existing system, it took ENT about 10 minutes to get there. And the equipment also came after we got there. with the new system that we developed, where a paging system was in place and there was a cart with a respiratory therapist that brought the cart there, the cart and the equipment arrived 4 minutes before we did, and 4 minutes sooner than it used to arrive. The time ENT arrived also dropped by almost 3 minutes. And those are things, when seconds matter, that can save lives. So we noticed that in that process, there was a lack of specialized equipment and no coordinated system with no written protocol. So when we improved those things, we felt that simulation was useful, both to design that system and also to ensure more rapid response times and elimination of simulation patient deaths. So some of our patients were designed to die at a certain time. They're all mannequins, but some of them died with the old protocol and not with the new. So when I got to Seattle, we also had similar problems and repeated a similar protocol. And looking at that retrospectively and collecting surveys, the blue lines on this side said everyone felt like we should use this cart in this protocol, and fewer people felt that we didn't need that. So part of that was these airway cards and signs. And so I wanted to share what we've used with that, which has been very useful. This is a fresh tracheostomy sign. And so when we deliver a patient to the ICU, we'll say, for this patient, we'll put a number 1 here. Step 1 is replace the trach. And step 2 is either mask, ventilate, or use an LMA, or reintubate, depending on the patient's airway. We'll document with a picture and words what is specific about that patient's airway, and then what the communication plan should be if that trach falls out, if there's an airway emergency with that patient. So that is sitting at the head of the bed for the team, the code team, to see when they arrive and try to save this child's life. So that's a fresh trach, and we've done the same thing for difficult airway and the same thing for critical airway. And that we've defined that in our institution as a grade 3 or 4 view on direct laryngoscopy, or a grade 3 or 4 subglottic or tracheal stenosis, or if they're unmaskable. And critical means that the whole team comes, including ICU, the OR is notified, the ENT attending, and trainees. Everyone's notified at once and everyone comes running. When it's difficult airway, it just means call anesthesia. Don't just try to have anyone in the ICU intubate, but be prepared, but it's not bringing the whole cavalry. So those have been incredibly useful in our institution in recent years. We're switched to Epic, and unfortunately, we now are stuck without the diagram, but it's really nice to have an electronic form that can be filled out, so it's always accurate information, and that's what we're using currently, which has been great. Lastly, I'm going to talk through some complications. So vocal cord ultrasound protocols are important. Unilateral vocal fold immobility after cardiac surgery in particular is relatively common. When retrospective studies looked at that, it was between 3 and 8% where a unilateral vocal fold immobility was diagnosed. But when you look at it prospectively and you actually evaluate for a immobility on patients, even if they're not symptomatic, that prevalence increases. The lowest number was 9%, and up to 52% of patients after certain cardiac surgeries may have a vocal fold immobility. So that for us underscored the importance of realizing that some of these patients may be completely asymptomatic or mildly symptomatic with some dysphonia or dysphagia, but a vocal fold may be immobile. And if you don't realize that and you're feeding that patient, you could actually compromise their pulmonary status, which can compromise your cardiac status and your cardiac outcomes. And our cardiac thoracic surgeons care deeply about their outcomes because they're reported nationally. So we have developed ultrasound screening protocols where after a postoperative patient, especially the high-risk patients like Norwood or aortic arch reconstructions, they will get an ultrasound postoperatively within 2 to 3 days of extubation, no matter what happened. And if that's normal and there's no clinical concerns for aspiration, then they just get a standard occupational therapy feeding evaluation and go down the normal pathway. But if the ultrasound is abnormal, or if there are clinical concerns, then otolaryngology is consulted. We generally perform a bedside scope. And if that scope is abnormal, will get a video fluoroscopic swallow study. If it's normal, they still go down their standard feeding plans. But if the swallow study is abnormal, then we have a discussion with the whole team and we consider early injection, inpatient injection medialization for those patients. If there's no, if we decide to wait, then we'll not do the injection, but we'll see them back in clinic and repeat a scope, coordinate a video fluoroscopic swallow study to be repeated, and consider whether we should pursue an injection medialization at that point for those patients. And then if they improve after the injection, we'll advance their diet. If they're stable, then they stay on their current diet. But we continue to monitor them, and some of them may need repeat injection medializations or a vocal fold reinnervation if they continue to have an immobility and dysphagia in the younger kids or dysphonia in the older kids. So these procedures have been increasing as we've implemented routine ultrasounds postoperatively, and I think that's been very, very good, a very productive partnership with our cardiac ICU colleagues. So that was ultrasound. Humidification came into play actually with that patient I showed at the beginning who had complete tracheal rings for nearly the entire trachea. So this is a model of her airway. It was cricoid down to mainstem with an LPA sling. And we rehearsed an advanced surgical planning session with her models to know what we should do with this airway and then perform the procedure. And it went great, as I mentioned, until the mucus plugs developed. And that was a byproduct, in my opinion, at least partially, of inadequate humidification protocols that we had established in the ICU. So I thought we were doing everything we could do to humidify the air these patients were breathing, especially around extubations. But when we looked into it in more detail, I don't believe that was actually the case. And after this developed and this patient survived, thankfully, there was a distal stenosis that I'm still dealing with, but they got out of the hospital. They're doing okay. We took that opportunity to develop an ICU continuous airway humidification protocol that was weeks and weeks of work, but the respiratory therapy and ICU teams were involved. And we developed this invasive mechanical ventilation protocol, both for kids less than 10 kilos and those older, to carefully consider the ways that we can have continuous saline humidification for those intubated patients. And if they're not intubated, also still to have a form of continuous humidification that's provided. So the last case I'll present just illustrates what all of these cases have shown is that teamwork is really the mainstay of what's most important, and communication is the central aspect of teamwork in these critical patients. So a 2-week-old had this stenosis heading off to her right mainstem. And if you look at the bronchoscopy, you could barely see an opening, and you had to kind of push your way into the right mainstem, beyond which it opened up. But we had planned again with an advanced surgical planning session to treat this right mainstem stenosis with a side-to-side slide tracheoplasty. So we did our advanced surgical planning session and did the model. This is preoperatively on the top and postoperatively on the bottom. And it all went great. When you prepare and you have a good team, this mainstem stenosis opened up beautifully, but there was a lot of raw tissue. And there was 2 interesting complications that this patient went through postoperatively. The first was illustrated by talks we had earlier about intrathoracic or extrathoracic stridor. So if you watch this patient's breathing patterns, the stridor is expiratory. So that should be an intrathoracic problem, and it was. There was granulation tissue around the anastomotic site. So we got a phone call from our ICU with clear communication of the problem. We took the patient to the operating room urgently that night on a Sunday night, and were able to treat the problem, and they got through that part just fine. And then a couple weeks later, they're in the ICU, and they developed inspiratory stridor. So you can't win. If it's not expiratory, it's inspiratory. But if you watch this stridor pattern, it's inspiratory. There's breath-to-breath variability, in that some breaths are more severe and some breaths are more subtle. And so I diagnosed this as an inspiratory partial episodic laryngospasm picture and put that child on reflux, anti-reflux measures, and that all resolved. But I was able to know about that immediately from our ICU colleagues and able to triage those two problems separately into the treatment they needed, which resulted in a good outcome. So 7 months later, this patient healed beautifully. Their family wants to be on our website because we communicated well with them and the ICU responded quickly to work together as a team to provide this patient what they needed. So that's a happy story to end. I think we got through everything. So my conclusions are that post-op care requires effective protocols, and there are a wide variety of patients that can be managed in a single stage fashion, which does require a more extensive, not only protocols, but teamwork and communication with your ICU team compared to the double stage procedures. Non-standard airways, so difficult, critical, and fresh trach airways, can be effectively managed with these protocols. That often includes airway signs and an airway response team. And if you're developing these protocols, it can be very useful to do some in situ simulations and roll a mannequin into your ICU and see what happens. You'll learn a lot about latent safety threats and pervasive knowledge deficits if you do in situ simulations to refine and improve your protocols in the ICUs. And then complications, they can be prevented or at least mitigated if you have effective protocols in place, but the protocols won't fix every problem. It does require effective teamwork and communication as the most important ingredients for success when managing these complex patients. So thank you so much for your time. I think I took a couple extra minutes, but acknowledging my team, and I think we'll do the panel next and save questions. Is that true?
Thank you, Dr. KAALAN.